Hello, and thank you for checking out FirstcallID Approach to Diarrhea in Adults. My name is Paul Bunce, and I'm an ID physician. We'll be spending the next 10 minutes or so going over some of the key aspects of an ID consultation. If you haven't done so already, please check out our first session on how to do an infectious diseases consultation, which covers a lot of the basics of consultations in general, whereas this session really focuses on the specifics of diarrhea in adults. Lastly, before we move forward, just a quick note that this content is for educational purposes only. Please refer to current guidelines and use your professional judgment in clinical practice. And I'll start by saying that I think that sometimes clinicians can be dismissive of patients suffering when they have diarrhea, but we need to be mindful of how impactful it can be on one's quality of life and occasionally their physical well-being. In fact, one of my mentors used to have a saying that doctors don't care if someone's having diarrhea unless they are the ones who are having it. So clinically, I actually appreciate the evaluation of patients with diarrhea. I think that the history is actually crucial. It can often reveal the likely diagnosis or at least a short list of potential causes. And so here are the key points to guide our evaluation of diarrhea from an ID perspective. First, we want to clarify the onset, duration, and pattern of symptoms, both GI symptoms and any other extraintestinal symptoms. We'll assess for risk factors for potential causes as well as someone's epidemiological history. We'll want to characterize the stool. Stool characteristics such as diarrhea, presence of melena, hematochezia, and stool consistency are actually worth noting. Although a person I've never actually asked to see a picture of the poop. We'll also ask about associated symptoms. Our physical examination will look at a focused abdominal examination, as well as evaluating for extraintestinal manifestations of certain types of diseases, and assessing someone's volume status in case they're volume depleted. Investigations can include blood work, stool studies, imaging, and sometimes more specific or specialized testing. And from this information, we'll come up with our impression and initial recommendations, again, from an ID perspective. So I'm not the biggest fan of medical mnemonics. I think there's only a few that I actually use routinely or even remember. But this particular one was actually helpful for me during medical school. So if you find it useful, go ahead. I'll let you take a look at the terms. So this is those, fads, wilt. And again, a number of specific risk factors or considerations diagnostically for someone with diarrhea. I'll also note that the image below was AI generated for a wilting fad, for what that's worth. So the first thing is to clarify the onset, duration, and pattern of diarrhea. Is this acute, over days or hours to weeks or even months? Are the symptoms continuous or intermittent? Right? Are there periods where there's normal stools or even alternating between diarrhea and constipation? We'll want to know if there's nocturnal symptoms. It's been said that nocturnal symptoms are more indicative of organic rather than functional causes, just because there's less of an input or impact on psychological factors in terms of the symptoms. We'll assess for risk factors for specific causes and epidemiological associations. So, has there been any travel that predated the symptoms? Are there any local outbreaks that they've been in contact with or any sick contacts? They'll take a sexual history. Recognize that some cause of diarrhea are caused by proctitis. Family history, specific for inflammatory bowel disease. We'll assess for immunosuppression or immunocompromised, so HIV, transplant, or other chemotherapy or immune-altering medications. We'll assess or ask about healthcare exposures, so recent hospitalization, antibiotic exposure, or even enteral feeds, such as tube feeds. Specifically, again, we'll make sure we ask about antibiotic exposure for risk of C. difficile colitis, as well as other medications and supplements that can themselves lead to diarrhea. A brief comment on immunocompromised hosts. So thinking about people who are living with HIV, especially with a low CD4 count, people who've received an organ transplant or a stem cell transplant, or other people with profound immunocompromise. I think for these individuals, we need to consider a broader differential diagnosis. Some infections like CMV are more likely. Other parasitic infections can become more prominent and with more protracted or prolonged symptoms. Tuberculosis and non-tuberculous mycobacteria, as well as other viral causes. And our testing will take this into account and will often be more broad at the initial stages and a lower threshold for endoscopy. We'll also consider non-infectious causes in these patients, such as GVHD in people with stem cell transplant, as well as some of the medication side effects. And lastly, we'll be mindful that patients who are very immunocompromised might have atypical presentations or a limited inflammatory response to a typically inflammatory diarrheal process. Next, we will characterize the stool as well as any associated symptoms. So watery diarrhea is often suggestive of viral or enterotoxigenic bacteria, sometimes C. difficile colitis. Bloody diarrhea, other bacterial pathogens like Shigella or enterohemorrhagic E. coli, almost never C. difficile if there's blood, except for in rare situations. Mucoid features suggest inflammatory causes. We'll also ask about associated symptoms, so fever, we mentioned abdominal pain, other constitutional symptoms that may be present, musculoskeletal complaints. And we'll ask about tenesmus, which is defined as a persistent, often painful sensation with the need to defecate, even if the bowels have already been emptied. And it may be associated with straining or cramping symptoms as well. With our physical examination, we're assessing the stability of the patient, vital signs, presence of a fever, and assessing their volume status, specifically evaluating for volume depletion. And also looking for evidence of systemic inflammatory or process that could be associated with the diarrhea, a focused abdominal examination, and also consideration, is there anything when I assess the patient as an internist where I would want to involve my surgical colleagues? Now, there are a wide array of investigations that you can consider when you're assessing someone with diarrhea. And what you order, what you send will depend a little bit on what your local microbiology lab has available, and also the clinical presentation of the patient. So you don't need to send all of this, but rather choosing tests based on your clinical suspicion and to detect conditions that you really don't want to miss. So we'll send routine blood work, so CBC, electrolytes, creatinine. Occasionally we'll send inflammatory markers like a CRP or a lactate if we're worried about someone's clinical stability. Blood cultures can screen for invasive bacterial causes, and in certain immunocompromised patients, you may actually send blood for AFB, looking for non-tuberculous mycobacterial infections like Mycobacterium avium. Serologic studies for both infectious and non-infectious causes can be considered. So you might send celiac serology in a fitting compatible case. In some patients with prolonged unexplained symptoms, you might send HIV serology. There are serologic tests for some bacterial pathogens, although those aren't routinely used. And in the right clinical setting, we may even consider strongyloidy serology. Stool studies. So for most patients presenting with diarrhea, if they haven't been done, we'll send stool culture for bacterial pathogens, which doesn't identify all potential bacterial causes, but the most likely or most common. C. difficile testing, and stool ova and parasites, especially if someone is immunocompromised or has more prolonged symptoms. In some settings, stool PCR is available to screen for an array of microbiological causes. And so if available, that's helpful, but not always something that everyone has access to. And you can consider stool AFB, again, if you're suspicious for TB, which can cause a colitis, or you can also use it as a screening test for disseminated mycobacterial infections, although detection of the stool doesn't necessarily reflect infection. It may reflect colonization in some patients. And then occasionally there's some other targeted stool studies that we can consider using. Some antigen testing for certain bacterial or parasitic pathogens. The gastroenterologist will often send fecal calprotectin. So there are some other things that might be considered. In terms of imaging, I personally like having a CT scan of the abdomen if it's available, being mindful of the radiation dose, just because it gives you a sense of localizing the inflammation in the bowel, which can help you with narrowing your diagnosis based on the radiologist's interpretation. So a helpful test if available and no contraindications. And then in some patients, based on this evaluation and the setting, you might recommend pursuing endoscopy. So this is sort of my approach to when I would consider or want to suggest endoscopy. Usually it's deferred until at least the early results are returning from the non-invasive testing. And here I'll say I suggest endoscopy because as an ID doctor, I'm not the one who's performing the test. And so I'm mindful that this is a recommendation to my colleagues who actually do perform this procedure and have a better sense of its risks and potential complications. Certainly I can advocate for endoscopy in certain settings where I think it's highly valuable. But situations where we'd be more likely to pursue this or recommend it, so if we're suspicious of CMV colitis or GVHD in people who've had a stem cell transplant, persistent or worsening symptoms without a diagnosis. You may consider this in someone who has severe abdominal pain or severe symptoms with a negative workup, persistent bloody diarrhea without an identified pathogen, or if you're suspecting a new diagnosis or flaring inflammatory bowel disease. And also, in general, you would be more likely to pursue endoscopy in patients who are immunocompromised for fear of missing other potential causes with non-invasive testing. So from this, we'll provide our impression and recommendations, which will often include a comment on infection control considerations, so whether or not the patient should be continued on isolation. It's often not an ID-specific recommendation, but something we can consider and work with our IPAC colleagues. We'll suggest whether supportive care is indicated versus empiric antibiotics, which are generally not recommended by ID doctors, but in certain situations, such as those patients with traveler's diarrhea, we might recommend empiric antibiotic therapy. We can advise on antimotility agents, which again, as an ID doctor, I'm reluctant to suggest until we have at least ruled out, to the best of our ability, infectious causes. And we can also recommend any additional investigations versus simply observing the patient. And again, whether we should advocate for pursuing lower endoscopy, we can certainly comment on that as well. So here again are the key points of an ID assessment for a patient with diarrhea. So again, clarify the onset, duration, and pattern of symptoms, both gastrointestinal symptoms as well as extraintestinal symptoms. We'll assess for risk factors for certain causes as well as the patient's epidemiology. We'll characterize the stool as well as associated symptoms. We'll examine the patient for any evidence of volume depletion or complications from the diarrhea, focused abdominal examination, and examining for extraintestinal manifestations of disease. We'll review the investigations and maybe recommend some specific testing based on our suspected cause and things that we don't want to miss. And from this, we'll provide our impression and recommendations and generally follow up with the patient. So there's lots of helpful reviews on this topic with varying depths of detail. The first is a relatively concise review on the topic from a few years back, and I think it's a helpful resource. The second is a bit more detailed in its approach, but still might be helpful to those who want a little bit more of an in-depth discussion. So that's all for now. I'm Dr. Paul Bunce, and we wanted to thank you again for watching. Please share any feedback you have about the session or about FirstcallID as a whole. And if you like what we're doing, tell us and tell a friend. Thanks for joining us.